All right, good afternoon. This is our didactic titled Night's Watch. Today's Night's Watch discussion will be on the fictional case of Sidney Prescott, which is the film Scream. So no wrong answer here. Where would this group like to start? Any particular scene, character that you think should jumpstart a discussion on Scream?
Start with Sydney.
Sure. Sydney, all right. So what did you notice in Sydney that you think we could help her with?
The idea of like her trauma with her mother.
Okay.
Obviously, a lot of the events that were happening in the movie were close or on the one of the mother or murder. So I feel like she obviously still dealing with a lot of that processing. Is still through.
So, and I don't know of the prequel, but let's assume that we were able to speak with Sydney. And is it Sydney? Yeah, it is, right? I'm make sure I got the right. And that she discloses that prior to the death of her mother, after a psychiatric review of systems, that there is no evidence of depressed mood, loss of interest, Siggy caps, dig fast, or psychosis. So it looks like everything we've noticed and we've observed in the film Scream is incident to the death of her mother. We'll kind of make this more of a simple case. Primarily thinking, do you think, and now I want you to think like an undergraduate, right? So we have undergraduates that are following us live right now. So it's part of a remote internship. If we were to poll the group of 20 as to whether or not this case is one of a mood anxiety spectrum, or B, psychotic dissociative spectrum, what do you think the majority of the undergraduates that are listening to us right now would say, A or B? A, okay. So that's step one. Step one is to make a commitment. And I would like you to consider always having A or B in your mind when you see a real patient too. If A, now we have to choose a single illness from which to start. There's no right answer here. This is an arbitrary decision. It's a group decision. It's really not. It's my decision. I want you to guess what I'm thinking as to what the hallmark illness of a mood anxiety spectrum would or should be.
I mean, even though she hasn't experienced.
No, not her. This is just generally
Oh,
speaking.
yeah.
Yeah. We're going to apply it to her though. So you're a step ahead.
Sorry, what are you asking? If they're like what?
For choice A, which is what the group's consensus is, we have to choose a single illness from which now to start our case formulation. Generally speaking, what illness should we arbitrarily agree upon would be our starting point? Sure. All right. You did, in fact, read my mind. All right. Step three is the appreciation that this condition that you chose, specifically major depressive disorder, is a diagnosis of exclusion. All right. So at this point, I want you to demonstrate your knowledge of the DSM. I want you to tell me what the inclusion criteria are, and then what the exclusion criteria are for major depressive disorder. So inclusion criteria first.
2 weeks, at least 2 weeks of 5 of the 8 symptoms or of city paths
Mhm.
would be the inclusion.
And at least one of which is
Oh, one of them is depressive
Or?
mover and anxiety.
perfect. Okay, they are, in fact, you just recognize the inclusion criteria for a major depressive episode that is a major depressive disorder. What are the exclusion criteria? Well, let's pause for a second. Now let's apply it to our case of Sidney Prescott. Does she rule in?
It's been a year.
This is at least 2 weeks. I'm gonna say she has a depressed mood. I'm also gonna say that she has anhedonia. We need 3 more. Does Billy actually provide her a serial sevens? Unfortunately, I'm not sure Wes Craven was that forward thinking. Any disruption in sleep, insomnia that we could? Good news, bad news. I agree with you. I'm not so sure she reaches 5. The good news, however, is that I want you to approach film analysis and using film to discuss these very topics as if you would be, or how you would approach a shelf exam. So if we are where we currently are, but in a shelf exam, and you had major depressive disorder as choice A, if choice B was schizophrenia, choice C, DID, choice D was dissociative amnesia, the single best answer would be major depressive disorder. So we get to say yes in terms of ruling in, despite the fact that in a true sense, if this were a clinical case and not a shelf vignette, I'm not so sure she does. Right, but we're going to say yes because that's the teaching didactic. Right, we're going to treat this as a shelf exam, as a case vignette. Demonstrate to me your knowledge of the DSM by now providing me the illnesses that the investigator would need to investigate and rule out in order to support the provisional diagnosis of major depressive disorder.
So you want to rule out in history like mania or hypomania, so.
Yep.
Underlying medical causes.
Okay. We have mania and therefore bipolar spectrum disorder. We have a depressive disorder that is due to an underlying medical condition. There's 2 more.
Substance use,
Good. Substance-induced mood disorder
and history of psychosis.
and schizophrenia. Perfect. Notice, again, in terms of this regimented way to case formulate, if in fact you were wrong, and this really should have been choice B, a psychotic dissociative spectrum, you would have arrived there anyway because you have to rule out schizophrenia anyway. So choosing A versus B is just choosing a path and how you are going to get to the most likely diagnosis. So do not worry about making that initial commitment, right? All right. Any evidence to any of these in this movie? Is Scream about a depressive disorder due to an underlying medical condition? So there's 2 ways. I think there's a 2-step process to approaching this question, and again, applicable to the shelf exam as well as a clinical scenario. Number 1, if you were to geek out and bring up the script for Wes Craven's Scream right now and use the search function for an underlying medical condition, would there literally be anything in that script? No. All right. And that's akin to our asking a patient who we're assessing for depression, do you have any medical conditions? What is your past medical history? Doc, none. In either case, should the clinician then be reassured that their depressive symptoms aren't due to an underlying medical condition? And the answer here, well, exactly right. The real answer is it depends, right? And it depends on 2 things. Now we're going to shift to the shelf vignette, right? The 2 things that will be protective factors that can, as a test taker, reassure you that this single best answer is not, in fact, depressive disorder due to an underlying medical condition are age and sex. If this were a 14-year-old female that presents to you, and in the vignette, similar to the Scream script, no evidence, no overt evidence of abnormal labs or past medical history, you can say that the patient is healthy. Okay. Unfortunately, an older male, you cannot say that. Okay. So let's apply that test taking strategy to the film. What do you think? There's nothing here, right? I agree. Second question. Is Scream a fictional case of a depressive disorder due to the direct and physiologic effects of a substance? And I want you to apply the same 2-step phenomenon. Number 1, is there any overt evidence in the script of substances playing a role in Sidney Prescott's depression? No.
If they use substances, but. Those are,
Yeah.
So no abuse. Okay. Given that, should then the clinician be reassured that therefore SCREAM is not about a substance-induced mood disorder? And here, I want you to be a little bit more aggressive. I want you to say, no, we shouldn't be reassured, because the clinician should never be reassured that the role of substances is not inducing the patient's presenting or chief complaint. That's just operating with a high clinical index of suspicion. That's all it is. So it's a little different than GMC or medical condition. So I want you to keep the differential of a substance-induced depressive disorder for Sidney Prescott, albeit probably low in the differential. Let's keep it in the differential nonetheless. Is SCREAM a fictional case of bipolar? No evidence of a manic episode. Now, in all honesty, we should be able to interview, provide a psychiatric assessment to our patient, and or have access to the prequel, which doesn't exist. So until, well, one would be Wes Craven, rest his soul, but until someone actually creates that, we have to say no. Again, if you want to be conservative and say, well, let's leave it in a differential until we definitively can rule out a past history of mania, that's fine too. And then finally, I'm going to guess that this group is going to say no to schizophrenia. In as much as you told me no already by choosing choice A and not choice B. So it looks like we have a case of depression here, when all is said and done for Sidney Prescott. Final step. All right, again, this is the way I want you to consider your case formulation and being rolled out in 4 discrete steps. The final step. If you were to have taken notes during this movie, and now are looking down at your notes page, and you could cross off everything that you've observed in this film that has been explained by what we just discussed, would there be anything left on that page? Because if your answer is no, we're done. We hit it. But if your answer is yes, if there's still things that are looking up at you that have not yet been explained, obviously we have to extend our differential. So. You think?
Probably still explore some other stuff.
Sorry,
We can still explore
what else would you like to explore?
acute stress disorder, following all the events. Potential.
So you think there might be an element of post-traumatic stress disorder? So you, on your notes page that you have in front of you, you see signs and symptoms suggestive of PTSD that you don't feel comfortable attributing to anything we previously discussed. Perfectly plausible. Okay, and actually, your observation fits perfectly well with the way in which we would address this unexplained information. That is, the first consideration is beyond depression, other depressive disorders within that same chapter, right? And if no, then extend it to the anxiety disorder chapters. And then if no, extend it to the rest of the DSM. So there's a 3-step progression there as well. And while your observation is not necessarily another depressive disorder, you nail it at step 2. You went to the other anxiety disorders. Remember, these are 3 discrete chapters now in the DSM-5, the anxiety disorders, the obsessive compulsive and related disorders, and then the trauma and stressor related disorders, of which PTSD is the whole. That's a consideration here as well. Did she discover her mother's body? I'm not sure either, but I'm also not sure that it matters, because as we remember from yesterday's lecture, you don't have to. Just learning of the event is enough now per the American Psychiatric Association. That's of 2013. That's of the revision to the DSM-5, right? So PTSD should be a clinical consideration. Just for curiosity and further discussion, what did you recognize in Sidney's case that led you to think post-traumatic stress disorder and not just a depressive disorder? Again, exaggerated startle, hypervigilance, avoidance behavior, and then nightmares, flashbacks are the ones that immediately come to mind, with the caution that if no across the board, there's 0 negative predictive value, because our patients can actually endorse further symptoms within those 4 symptom sets that allow for us to actually rule in PTSD nonetheless. But I think the first step would be the 5 core symptoms that most of us think are defining of PTSD. Anything there? In the absence of those 5, again, no, there's 0 negative predictive value. Anything from the constellation of, let's call it the other category. Those are less common things that those outside of psychiatry would consider to be PTSD, but we now know are part of the PTSD picture. Anything there? The one thing that I'm concerned about is her negative affectual state and her inability to actually find satisfaction with things. That's part of the what was actually fractured off of the avoidance criteria, not necessarily explained in thinking caps, but certainly would be consistent with PTSD. Right. I think that's a buy-in. All right. So and again, is there a reach here? No, because we know that a significant number of individuals with depression have PTSD and vice versa. There's a significant comorbidity between these 2 illnesses for obvious reasons, like discovering or learning of the premature death of your mother. Anything else for Sidney Prescott? If you remind me, and this is after we shut this down because it's too big of a rabbit hole, and quite frankly, those listening along at home or on Instagram are going to have a venue to discuss this further, and I don't want the answer to be disclosed now, but remind me in logging off of perhaps other information being provided outside of the depressive and PTSD conditions that we just described. And this one would be related to post-traumatic stress disorder, and I'll just kind of lay the teaser out like that, and when we shut things down, we can discuss that further. Other than Sidney Prescott, any other observations of characters in this movie?
The 2, Billy and Sue.
Okay, Billy and Stu. Observations, thoughts, comments?
They're crazy.
So they do have some issues. I don't think there's, well, I mean, it's going to be difficult for them, but if the ending would have been different, I don't think it's I think it is reasonable to assume that they might actually come to clinical significance for psychiatrists. They might actually we might be actually consulted. So here we are. So we don't want to say crazy, because if a particular lawyer actually hears us say that, they may actually have a defense.
Okay, I was like, why did everything he did?
Yeah, I mean, that's an insanity defense. Now, just because hypothetically, and I'm not saying that Billy Loomis actually has a psychotic disorder, but hypothetically, if they took our words verbatim and they submitted your medical record documentation as evidence, that would be a necessary step for the insanity plea. Now, of course, there's an extra step in that, despite what the illness is, that in the context of that illness, Billy did not understand what he was doing, right? Which, of course, I'm not so sure 12 of his peers would buy into, especially that fan base of Scream is huge. I'm not sure you can even find 12 that would exonerate Billy Loomis in this case. So, nonetheless, what do we think is going on with Billy Loomis? Again, if you want to look through those 4 or 5 steps again, and you don't have to actually say them out loud, but now I want you to start to process them and kind of maybe even jump to the end about where they that process may bring you.
Is it like personality disorder? Yeah. I want to know a little bit more about his childhood. And the discussion of like conduct disorder, transition into antisocial personality.
Yeah, so so again, we could kind of piecemeal some of this together without knowing the full backstory. And again, the full backstory, in as much as that it's not in the movie and it's not in subsequent movies to any significant degree anyway. But what we do know is that his mother has had an extramarital affair. That could be something that's simply in a vacuum and simply her choice. or it could be a product of something much, much deeper. As a psychiatrist, I think we should never dismiss a behavior as something to simply shrug off, especially when it causes so much clinically significant distress and impairment in her son. So there may have been stuff going on in the family that resulted in Maureen having had that affair, and might that family dynamic be contributing to Billy's symptoms that now we're identifying as a teen/adult. All right, so that's something we have to inquire about.
Lack of remorse, especially, the killings were pretty gruesome. It wasn't just like, gunshot, it was like multiple stabs, chasing people down.
Yeah.
Torturing, taunting, filtering,
Mhm.
and especially against those who you consider friends. Or so-called friends.
Right, it's his girlfriend.
Mhm.
Well,
Mhm.
loosely, but the lack of remorse comment is certainly something that is literally published in the DSM as part of the criteria for a condition known as antisocial personality disorder. Lack of remorse is but one of several examples of which an individual is required 3 that hallmarks a blatant disregard for and violation of others' rights. Right, which clearly Billy, I think, manifests. It does depict that. So with this idea, I would assume that when you now go through this symptom checklist, we're going to be able to find 2 additional criteria and therefore meet that threshold of 3 for Billy, which will result in our asking what?
Why?
Always. Psychiatrists always ask why. But as far as diagnosis is concerned, first, before we get to the why and what caused the illness, we have to diagnose the illness. And there's one more part of this diagnosis that we have to address.
The history of conduct disorder.
Exactly right. Right. I want to know if there's any evidence of destruction of property, any cruelty to animals, any kind of rule breaking, truancy, etc. Because if the answer is yes, and I think there's 4 or 5 subcategories that define conduct disorder, if there's any evidence of conduct prior to the age of 15, we may actually have a provisional diagnosis here. That's the next set of questions. And again, we don't know the prequel.
So just for conduct disorder or for antisocial personality disorder, it just has to be like in keeping your history, if you find evidence of it. It doesn't have to be the fact that they were in fact.
Exactly correct. Yeah, I mean, 'cause I think it's reasonable to assume that perhaps due to barriers to healthcare, an individual just never saw a doctor or a psychiatrist. Yeah,
Could
so-
that be used as like a defense? And for like,
Yes,
it can be-
yeah, if in the context of that condition, you can prove that the individual did not know what they were doing. Now, that might be easier to do with an established psychotic disorder than an established personality disorder. And quite frankly, if I heard expert testimony that due to his antisocial personality, Billy did not understand the nature of his crime, the nature of his behavior, as someone who's called for the prosecution, I think I could tear that apart. Or much easier so than someone with an established psychosis or psychotic disorder. Okay. Let's say that there is no evidence of conduct disorder prior to the age of 15. Matter of fact, what we learn, Billy, collaterals, is that there's actually no signs or symptoms of any mental disorder, personality or otherwise, prior to 15 or prior to the death of his mother. Now what? The other way to say this is that all the behaviors that we're seeing manifest in the case study known as SCREAM are incident to Billy's discovery that his mother had an affair and died.
Or like,
Dead or divorced? I'm sorry, divorced.
yeah.
I think Maureen's dead. Maureen's dead though. Yeah.
His father had an affair with Sydney's.
I'm sorry. I'm taking it back. Right. Sorry about it.
It's more like trauma.
Yeah. So I think we go down this same exact road as we did with, ironically, Sydney, his quote unquote girlfriend, his air quotes, right? We think the depressive disorder, and this might actually be the way Billy deals with his depression. And if so, all right, hypothetically, if so, I would not expect Billy to ruin for Siggy Caps. Siggy Caps was created, constructed for individuals, cohorts that owed to the actual building and construction of the DSM that were able to verbalize their feelings. Right, Doc, I feel down and sad, right? Hence depressed mood, anhedonia, and sticky caps. For people who have difficulty putting words to their feelings and otherwise feel more comfortable communicating non-verbally, sticky caps is not going to fit. Easy example would be children. Right, children who are depressed are not going to come in ruling in for sticky caps. They're going to come in with behavioral issues, non-verbal communication. So in this way, we can begin to maybe put a little bit of a formulation to Billy's behavior if it actually is true that all of his signs or symptoms are incident to the discovery of again, is Maureen dead? I think because I'm the way I say the reason I'm saying this, I did not watch Scream this week. However, I've looked up the Loomis family tree and I see that she's deceased as well. So she may not have been dead actually in this movie, but I know that she is deceased nonetheless. So I don't want to confuse the issue. Okay. In either case, it's upon that discovery that we see the onset of symptoms, right? So maybe Billy has that same catecholamine dysregulation. Maybe there's some dysregulation of dopamine and or norepinephrine and or the indolamine, that's serotonin, very similar to the CNS of his girlfriend, Sydney. But instead of being able to put words to those feelings, he actually non-verbally communicates through defense mechanisms. And this defense mechanism that might be Billy's go-to could be acting out. Therefore, putting some kind of an understanding to why he's behaving the way he is. Those behaviors are consistent with antisocial personality disorder, despite the fact that there's no evidence of conduct prior to the age of 15. So acting out might be a maladaptive defense. Now, one of the inquiries we have, again, any evidence of cruelty to animals, destruction of property, etc., as a child. But if no, the other question I have for Billy or collaterals, is there any other evidence of use of the maladaptive defense of acting out? Because if I hear yes, if I hear that there are like impulse control issues as a youngster, even though no established diagnosis, and therefore acting out is this guy's go-to and it's rigid and maladaptive defense, I think we can make more sense of his current behavior. We know the etiology of it, and that's the biopsychosocial, that's the psychological aspect of the etiology of his blatant disregard and violation of others' rights.
I would have a question because given how he presented at the end of the movie with justification, it seems some level of satisfaction with the outcome of his action. I was just wondering if that like level of satisfaction or enjoyment, that response from the action or the acting out distinguishes it from like a specific, disorder or personality disorder. With that like level of gaining, enjoyment from the action change how you would think about it?
Not really for the differential we've created today. There is a group of disorders formerly known as the impulse control disorders, in which that could be true. So if people have a condition like intermittent explosive disorder, after the intermittent and explosive episode, they can in fact be dysphoric, feel guilty. And on SHELP exams, we often see that as a distinguishing principle between an impulse control disorder. And that includes pyromania, that includes kleptomania as well, versus those same types of behaviors, but due to another condition such as antisocial personality. So yes, but not necessarily as we applied it here today, because I don't think an impulse control disorder is in Billy Loomis's differential. Other thoughts about Billy? How's Stu different? Is Stu different? How?
His motivation is versus Billy having some sort of reason given, you don't really have too much of a reason.
You know, right? Mhm.
Yeah.
I mean, at least he uses as an excuse or that he's easily.
And I agree. I think in watching this movie, and of course, because of the ending, because of the reveal, we know exactly now what's happened, and we know that Billy is the brains, and this is all a result of what happened to his family due to Maureen, etc. So or not a Marine, it just takes two, Marine and Billy's father. That, all that said, I suspect that if both of those young men came to clinical observation, ultimately, we would have a fantastic story of who Stu is. So any speculation as to what we would find here? What are some of the things you did pick up on? And let's kind of delve into this a little bit. So first of all, there's a nice juxtaposition with what now we understand as Billy's home life, especially the role model in his home, and Stu's, because at the end of this movie, there's a tagline that is uttered by Stu, which is what? Yeah. Yeah. So that seems to suggest that there's parenting going on in the Stu home. Right? There is. That's good to know. Yeah. So if that's the case, and I think that further justifies or at least supports our idea that these two friends are coming from different situations. They come from different directions. Let's look at the direction that Stu's coming from. How can someone with that level of parenting, the first thought is my parents are gonna be so mad. That's a normal reaction for a kid, even a teen, right? So, I mean, if you know, bender, first thing, oh, my parents are gonna kill me. It's normal. But his actions are not normal. So we got to make sense of this. And for once, a psychiatrist is not going to blame the parents because it looks like they actually are doing the right thing at home, at least for Stu. So what then?
Fantasy.
So fantasy. So we would expect Stu to have engaged in fantasy because everyone's sitting around this table, likely engaged in fantasy, 2, 3, 4 years old. Don't anybody raise their hand. I don't want anybody sharing. I don't put anybody in a spot, but if anybody had a teddy bear or a blanket or an imaginary friend, we've all done it. Okay. The imparting of humanistic qualities to inanimate objects is part of fantasy. Specifically, the defense mechanism is called animism. All right. So if you've had a blanket, ever had a teddy bear, animism, it's kind of a spin-off of the defense mechanism of fantasy. Fantasy itself is the creation of this inner world that allows us this autistic retreat so as to protect us from the stress of the real world. All right, so imaginary friends, tea parties, that's all part of fantasy and fantasy play. Completely normal when age appropriate. Unfortunately, some people are not necessarily 5 years old doing this, but more of Stu's age, where that continues and it becomes age inappropriate, and it could actually be the focus of clinical attention. So we have to consider that. Is there any evidence in this movie that this kid is operating in a fantasy world? I don't see him talking to an imaginary friend. Again, when you walk into your son or daughter's room and you see them talking to an imaginary friend, do not call 911. Don't call me. It's normal. It's completely normal. Right now, again, if we actually had the camera pan into Stu's room and see Stu talking to an imaginary friend, that'd be creepy. Right? That would be akin to a horror movie. But I don't see that. I missed it. So, what other aspects here would we consider? Anybody here see the Rock Horror Picture Show? Oh, you guys are in for it. Nobody, huh? All right, so there goes that example.
There's like, I don't know if it's an obsession, but like a fixation on horror movies and like the fantasy of that, like the plot line, he's always talking about like, oh, how awesome it's gonna come out to be as opposed to a horror movie, or he's always talking to the other friends about the design of horror movies. So he does seem to have some sort of fixation.
Yeah, that's it. Yeah. I would suggest, now I don't think there's any true breach in reality testing. I don't think he's psychotic. But what I do believe is perhaps through the maladaptive defensive fantasy, this is a person who every now and then is not completely sure whether he's in a horror movie or not. But the irony, of course, is that he is. But only we know that. And that's Wes Craven, and that was intended. Again, the general idea here is that this individual I think if we can actually pick his brain, if we can provide a psychiatric assessment, may go in and out of this idea of who he is. Is he, and I would ask him, any feelings of depersonalization where you don't feel quite yourself? It's almost like you're acting in a movie, you're playing a role, and you don't have full control over your body or your body functions. Because I would suggest the answer is going to be yes. Right. And I see him and the way he actually was in that video store. I think a lot of his personality developed by which movies this kid actually watched. And he begins to kind of incorporate and take on the characteristics of the people that he identified with, despite the fact that they're fictional characters. And at some point, he gets lost in that and he begins killing. And I think that once Billy decides to do what he does, it's a perfect storm for Stu. Because now you have that outlet, you have that opportunity. So I think this character is much more complex. And despite the fact that I think there's quote unquote proper parenting, at some point, I don't want to use the word neglect, but perhaps given his own independent time, he actually began to really immerse himself in film, where he kind of lost touch of who he is and developing his identity. Right. And that is consistent with adolescence. Remember, this is consistent with Ericksonian teaching, right? So when you look at Erickson's psychosocial stage development, teenage years, adolescence is isolation, identity versus isolation. And that's the struggle for this teen. And unfortunately, he begins to identify with the aggressors in these fictional movies. That is the Rocky Horror Picture Show.
I don't know if it was clear if it was Stu necessarily that killed Tatum. But couldn't, if he was the one that necessarily killed her, couldn't that strongly look towards, someone that you have a relationship with overcome the you personally?
Yes. Yeah. Although, and then maybe that's testament to how far gone he is. Then not even that empathy he would have or should have built towards her would have overcome that, because it didn't. If he was the one that killed her. Yep. Any other films or other media kind of have the same theme where a person just begins to kind of take on the personality traits of those around them because nothing comes to mind. I'm just interested in.
He starts to kind of adapt the lifestyle of this couple. It's a movie, where in the Fantastic Mr. Void, something like that, he goes with this couple on vacation, he meets them, and he starts to kind of incorporate himself into their lifestyle and like delusionally becomes.
Do you know the actor?
I'll look it up. Yeah.
Okay, go for it. I'm blanking on it. There's a little known, anybody here horror fans? Well, that's what I guess. Have you seen the movie Creep? Yeah, that character does the exact same thing. Yeah.
Talented Mr. Ripley.
Oh, yeah, okay. No, all right. Yes,
Kind of.
yeah, but he's a con artist.
Yeah. He's
Yeah,
a-
yeah. A great movie. All right. Any other characters you care to discuss here?
I don't remember his name, but the friend that like knew all of the horror movie tropes and like what was-
Is that Randy?
yeah, Randy.
So what did you identify in Randy? Yeah. I actually like him as a compare and contrast to Stu. I mean, somebody who knows the tropes and the lines and everything as much as Randy does, but yet understands who he is and has a solid identity. I think clearly can be compared to Stu, who has probably the same exact background, same exact experience. And these guys may have been actually best friends, but clearly then going totally opposite directions because Stu is the one who fails to assume that identity during adolescence, and therefore, as Erickson would state, is in isolation. I'm sorry, I keep on saying isolation, is role confusion, which makes a ton of sense because he's confused, having adopted multiple roles from multiple villains from multiple movies. Whereas Randy, not at all. I think Randy is cerebral, so all of this stuff is kept in that cortex. So he's able to state those different taglines, etc., but yet has a understanding and a fundamental understanding and identity. But beyond that, is there any other problematic behavior that you may have recognized or observed?
Yes, you could say he didn't notice when his two best friends were like gone killing all the time.
We make it happen. And again, as a psychiatrist, I always want you to think that irrespective of what your patient's chief complaint is, and it's irrespective of how quote unquote obvious, problematic you think the behavior is, I want you to train your brain as to considering that the patient is completely normal. And then you begin to look for evidence to the contrary, and it might take you 3 seconds. But when you get to T+3 and you're there, and you begin to think, all right, is this choice A, mood, anxiety, etc. I don't want you to think of, oh, Toby made me waste 3 seconds. I want you to think that that's the exact way my brain should be working. Unconditional positive regard until proven otherwise. Right. So let's apply that to Randy, and maybe this guy just missed the signs, and who wouldn't? Is there any evidence in this movie, though, that would move us away from that starting point and reconsider and say, wait a minute, there's something else going on here?
Well, he seems to know everything about horror movies, but he misses all of like the obvious signs that he's in one.
It's true.
That's all I have.
I feel like people don't wanna see when you're, oh, things bad would happen around you, and that instinct would be like over a movie.
Or my best friend's a murderer.
Or my best
I
friend,
would, you know,
like a very low bar for
Mhm.
what I
Yeah.
think of my best friend, that was my first thought.
Now, again, I think somebody, and it might be around this table, or if you could actually think of this as a real life scenario, somebody might actually say, though, how does somebody miss those signs? And that's usually the inevitable question we ask. I mean, we see this all the time, whether it's school shootings, serial murders, etc., that people have missed the signs. The neighbor's always behind a microphone saying, oh, he was a shy kid, but a good boy. I mean, and then the millions of viewers, Fox, CNN, doesn't matter, ask, well, how do they miss the signs? Again, our first inclination is to say it's completely normal. It happens. My question is there any evidence in Randy's case that would suggest otherwise? I don't know the answer, but that's the general idea here. So one of the first questions I think in clinical practice that I might consider, and therefore probably would ask, is, according to Randy, is what do you look forward to doing? What's important to you? Because as a team, if he is preoccupied with something, whether it's age appropriate or not, that preoccupation may have had him miss what's going on around him. Right? And again, the answer might be yes, but still be normal, right? Because teens tend to be preoccupied with stuff. Adults tend to be preoccupied with stuff. But if the answer is yes, the next question, of course, is, well, is it pathological? Would it be in the context of a mental disorder? And that would be our purview. But you could see that any step across, as we go down this line, the conversation could stop and we could say, no, there's really nothing here.
His in his like interest in about his judgment, like other than his system. So he has been education about really maybe the murder, but I think like the idea that probably doing that with judgment.
Yeah. So, and that's where I was going with this. So is there any evidence that he is preoccupied with Sydney?
Trying to think like a way to like inserting into that relationship. Like, you don't have to, number one, who's going to that party, you're like, oh, it seems like they have me, like, still trying to like find those, like, initiate themselves.
That could very well be the case. That could have definitely been his preoccupation, and it might be an example of someone in fact being preoccupied, but again, that preoccupation being well within the realm of normality for a male teen. Right. It could be, yeah. Any other observations, whether it's Randy or any other characters in Wes Craven's Scream? All right, we're going to end it here. We'll come back at 1 o'clock to kick off our clinical case conference. See everybody back then.